Good morning, everyone. So I think that's the final paper of the session, and slightly unconventional. That is the oncological and functional outcomes of unconventional histology of prostate cancer, and it's a multi-center 5 year study. So we all have seen these patients. Very rarely we see these patients, and we all wonder. We know it is bad, but we don't know exactly what's the prognosis. So we know adenocarcinoma is the most prevalent cancer histology. Unconventional histologies are present. They are rare, but yes, they are present. Of them, most common is cribriform pattern, which also comes in Gleason grade 4. Ductal adenocarcinoma and ductal carcinoma are second and the third most common. And all of them, as a broad, when we say that they have, bad outcomes. So just to give background definitions, so cribriform pattern is, confluent sheet of cells with, without not much trauma. Ductal and ductal carcinoma, they almost have same pathology, but if the basal cell layer is intact, it is intraductal, and if it is not, then it is ductal. So why are we, why are these studies even needed and get published in European Urology Oncology? Is most of the data on this is old. The details regarding surgical improvisation has happened. Even radiation has improved over time, and impact of this on particularly functional outcomes is not much known. And what should be the adjuvant treatment? That is also, what is the exact recommendation on adjuvant RT? That is not known. So this paper is just a background. It's not suggesting any guidelines or anything, but just a practice or experience paper. So they're trying to provide the contemporary updates on the prognostic value of unconventional histology. What are the rates and the differences on adjuvant radiation therapy? And compare the impact of this unconventional histology with the pure adenocarcinoma on the oncological and functional outcomes. It's a retrospective study from 16 to 2020. When we talk of a study, we always simplify it with the PICOs. Patients are the treatment naive localized prostate cancer treated with robotic prostatectomy. Exclusion criteria was, any previous prostate cancer treatment or any other mixed histology. Intervention, basically like comparing two groups. So one is the pure adenocarcinoma is a comparator. Intervention is unconventional histology. And outcomes divided in two terms, oncological and functional. So in oncological, this is the BCR, which is classical as prostatectomy, defined it like 2 rising PSA and PSA more than 0.2, and adjuvant receipt of radiation. Then what is the incidence of positive surgical margins, lymph node involvement, and nodal and distant mets? And functional continence, so they took as social continence, that is 1 pad per day, and potentially just to have an adequate intercourse half of the time with or without use of the supplements. Stats, pretty straightforward. They used a Cox regression and used SPSS. And what they tried to do, because of such a heterogeneous cohort, so they divide into 4 groups, that is Gleason grade 1 to 3, Gleason grade 4, Gleason grade 5, and then unconventional histology. So of all the database from 5,005 patients, overall pure cancer was pure carcinoma, about 3,000 patients, and majority of the patients. 174 were in group 2, which had, adenocarcinoma cribriform pattern. Ductal was 447, and intraductal was 188. Looking at demographics, so median age was 65, PSA was around 6.8, which is fairly low in that sense. Prostate size was 38. Median follow-up was 2.8 years, and median PSA was similar in the patients with intraductal or cribriform pattern, but was lower in ductal adenocarcinoma. So this is more of a fact paper, what they found. And Gleason grade 2 to 3 disease was, present with unconventional histology, and then DAC was 67%. So, not go to basic sense of the paper. The worst was cribriform pattern, which we always generally know and counsel according to that. The next was the intraductal, then Gleason grade 5. Grade 4, data percentages are mentioned here. So, IDC has 17%, ductal has 10%, and cribriform has 17%. And they all appear to be a significant independent predictor of, biochemical recurrence. Again, same thing, the ductal, intraductal, and cribriform pattern, along with PSA and stage were the predictors for the recurrence. An important thing was the positive surgical margin and positive lymph node in their database did not, appear to be a predictor for the biochemical recurrence. Coming to the oncological outcomes, other outcomes, the positive surgical margin, highest for cribriform pattern, metastasis, highest for intraductal pattern, lymph node invasion, again, intraductal pattern is highest, and adjuvant artery, intraductal is highest. So grossly, we don't want to go into exact figures, but grossly, the unconventional histology, poor oncological outcomes. These are the exact percentages, will not waste time in that, but grossly, so margins are very much positive in cribriform pattern, while other things like lymph node invasion, metastasis, and adjuvant RT, they were all higher in intraductal cancer. Now, when, adjuvant RT predictors, so ductal adenocarcinoma, intra and intraductal carcinoma and cribriform, all of them appear to be the predictor for the, sorry, not the cribriform pattern, but ductal and intraductal, both of them appear to be the independent predictor for the adjuvant RT. Coming to functional outcomes, which was not actually well studied in previous literature. So they said that if you have cribriform pattern, there's 2 times higher risk of incontinence. And of course, these patients also had higher positive margins. And even ED was at higher risk with unconventional RARP, like unconventional histology. And then they found that ductal and intraclara are independent predictors for erectile dysfunction, which is relatively a new message from this particular manuscript. So coming to the limitation of this study, it was a retrospective study, lack of central review of pathology. When you're talking of pathology paper and you don't have a central review. So yes, that's a major limitation here. Lack of pre-op imaging, omission of some of the other entities like mucinous and neuroendocrine diseases. They don't have any standardized protocol. It's a retrospective analysis of 5-7 centers. So the conclusion is, grossly the take-home message that unconventional histologists 3 to 5 higher times risk of VCR, that is recurrence at 5 years, compared to the pure entity. Intraductal carcinoma and ductal adenocarcinoma, they need adjuvant radiation therapy, 27 times and 3 times higher chance. Early overall in all of the unconventional histology, higher rates of adjuvant in ductal and intraductal carcinoma, and presence of any of this unconventional histology, increase the risk of erectile dysfunction, and cribriform pattern increases the risk of incontinence. And so, all this thing just lets, need to have important counseling, need a multimodal treatment. And I think one of the common methods, if you have unconventional histology, you would, try to get your candidate done adjuvant radiation therapy. And I think that's Thank you.
Thank you, Dr.